Hello, am I audible, ma'am?
Yes, yes.
A very good morning to one and all who have gathered here through this virtual mode. So before that, I would like to wish everyone a happy World Physiotherapy Day. So this is me, Dr. Aishwarya Vardhani, Assistant Professor from the Faculty of Physiotherapy, Dr. M.G.R. Education Research Institute. I take immense pleasure to do the Master of Ceremony for this event. Thank you so much for the opportunity. So before we begin, I would like to quote a famous saying by John Dewey. He has mentioned like education is not preparing for life. Education is life itself. So that sounds really good, isn't it? Because we physiotherapists, we educate the patients and thereby we add life to their years. So with that great saying, we can just go ahead with today's event. So we have two sessions today. So before we begin with, I would like everyone to rise up or for the Tamil Thai வாழ்த்து. Now, I would like to request our Honorable Principal, Sir, Professor Dr. C.V. Sendilnathan, to address the gathering. Over to you, sir.
Thank you, Aishwarya. Am I audible to everyone?
Yes, sir.
On behalf of Faculty of Physiotherapy and my students, I wish everyone a very happy World Physiotherapy Day. We, the physiotherapists, relieve pain, rehabilitate, and we do a lot of things for the welfare of the patient. Doesn't mean that we are the one who does everything. We are a part of the team, and we play a major role in that team. So everyone should keep it in their mind and don't think that we are superior to others and we are inferior to others. So we are equally important in the team. So that is more important. And today's World Physiotherapy Day theme, long COVID. This is theme of this year, but we are conducting the program in the topic in cancer. But anyway, I warmly welcome both the speakers of today's session, Dr. Rupali Merlin and Dr. Parvati, who have a very extensive knowledge and wide experience in our field. And I warmly welcome them for having consented to our invitation to share their knowledge. I hope everyone will imbibe their experience and knowledge. Thank you one and all for having invited me to give this welcome speech. And I wish everyone a very happy World Physiotherapy Day. Thank you. Thank you all.
Next, I would like to invite Dr. Satya, Assistant Professor, Faculty of Physiotherapy, to give the welcome speech.
Thank you, ma'am. A very good morning and a warm welcome to one and all present here for today's online webinar organized by Faculty of Physiotherapy in association with IAP Women's Cell on the occasion of World Physiotherapy Day 2021. It gives me immense pleasure to deliver the welcome address today. My hearty welcome to our Honorable Founder Chancellor, A.C. Shanmugam Sir, our respectful President, Engineer ACS Arun Kumar Sir, our Honorable Secretary, Thiru A. Ravakumar Sir, and respectful Vice Chancellor, Professor Dr. Geeta Lakshmi Ma'am, for today's event. I would like to welcome our respectful Principal, Dr. C.V. Sendilnathan Sir, our Vice Principal, Dr. Veena, and Dr. Rajalakshmi Ma'am. Welcome, ma'am. Welcome, sir. I extend my warm welcome to the distinguished invitees of today's event, Dr. Rupana Merlin Jaising and Dr. Parvati Sampath. Welcome, ma'am. I extend my hearty welcome to the participants of IAP Women's Cell, Tiruvallur district for today's event. Not but not least, I welcome all staffs and students present here for today's webinar. Welcome you one and all. Thank you.
So before we start with the session, we would like to show a video which explains the metamorphosis of our college. So all take time to watch this video. Thank you. Thank you for being patient throughout the video. So that was a great. So hope we continue to achieve great heights under the blessings and guidance from our honorable chairman sir, president sir, and our secretary sir, and last but not the least, the captain of our team, our honorable principal sir. So next we'll begin with the session for the day. We'll go with the first session. So now it's time to introduce the first speaker of the day. So I would like to invite Assistant Professor Dr. Kamachi to introduce the first speaker. Kamachi ma'am, over to you.
Thank you, Aishwarya. Good morning to one and all present here. At this onset, I would like to thank the management and our principal, Dr. C.V. Sendilnathan sir, for guiding us and supporting us and actively involving us in the activities in association with IAP Women's Cell, Tiruvallur District. Thank you, sir, for giving us an opportunity to explore. Thank you, sir. Now I like to introduce our speaker. It is my proud privilege to welcome our guest speaker, Dr. Rupna Merlin Jayasingh, senior physiotherapist with 19 years of experience in the field of physiotherapy. She has worked in the Noble Hospital, AL Taya Club for Handicapped UAE, Sharjah, and reputed multidisciplinary organization at the present. At the present, she is a consultant physiotherapist in Physio Bliss. Welcome, ma'am.
Hi, you're able to hear me, Kamachi?
Yes, ma'am.
Can I go ahead?
Yes.
Hi, good morning to all. I would love to wish you all a wonderful physio day. It's been a great pleasure to be with you guys this morning.
Thank you, madam. Thank you very much.
Morning, sir. As my topic that I selected is physical rehabilitation for patients with oral cancer. As when we move towards the topic, you will understand why I selected this topic. And very specifically to oral cancer, because when I would like to start with head and cancer, it will go into a very deep speech that we need to cover everything clearly. So that's why I selected this topic, and we have few case presentation where you will like also. All right. So this morning, the second slide, please. Dr. Kamachi, please do change the slides as I go through, so that the students will be much benefited. The second slide, this is today's agenda, where you can, I would like to go the brief topic on all these, so that you guys can gain knowledge. I heard that students are participating, so keep them into consideration. I'm going to speak few topics which might be known to the senior persons who are watching this. All right, third slide. This is about my personal profile and my career profile into. Been working here as physio for past 20 years. It is a long journey, ups and downs in every place that God has taken me. It has made me to learn few good knowledge, so that I am so happy to share this morning with you all. All right, we'll go to the topic. So the fourth slide. So as you all know, what is cancer? It is a disease involving the abnormal, it is an abnormal cell growth, which has the potential to invade into the other parts of the body. There are trillions of cells which has been there in our body, and they multiply when it requires, when it receives the signal from the brain. But when this orderly process of multiplication is being broke down, and where abnormal cell damages take place, and cells multiply without even the signals to the brain, and it invades into the other parts of the body, which is called as cancerous cells. Usually when the cancer cells get multiplied, they might be forming into a tumor, and this tumor might be a cancerous or as well as non-cancerous tumor, which will be found out only by the investigation procedures. Fifth slide. In this slide, I will show you the difference between the normal cells and the cancer cells. See, when we receive growth signal, cell growth signals from the brain, our cells grow, and it will try to cover the tissue damaged places. But then in cancerous cells, they grow even when there is no some signals of growth from the brain. So what happens is in normal cells, when they encounter with the they do not encounter with the other parts of the cells. Whereas when the constructive tissue has been done, they stop the growth. But then in cancer cells, this process is being continued. So when there is an invasion into the other parts of the body, naturally the immune system is also getting tricked out whether how to behave in this marriage, and it has been confused to cope up with our body. Right? Fine. We will move to the sixth slide. So this is the just the show the type of cancerous cells that we have. See, the carcinoma cells are ones which has been found in the skin, lungs, breast, pancreas, and other organs and glands. The sarcoma, which involves the bone, muscles, fat bodies, and even the cartilage, the connective tissues of the body. Melanoma involves the cell that involves the skin pigmentation, and lymphoma involving the lymphatic system of the body, and which is the fighting, which help us to fight the tissues. But then when lymphoma is affected, the lymphatic tissue is completely affected, and the immune system gets damaged quickly. Then the next one is a common leukemia, which is the blood cells, the entire blood cells which has been affected. These are the types of cancer cells, right? I'm sure your lecturers and your professors will cover you on this deeply when they take subjects on this. All right, stages of cancer. So, the first stage is when they do the like investigation procedures. When they found out the cancerous cell just in the early stage, just the dot or a spot where you can only find few cells, that is called the early stage. People on self-examination finding the stage is little difficult, but then when we find cancerous tissues growing in this stage, it is very easily can be cured. The second stage is it is localized, but the tissues have been grown to a next extent where you can find the mass. The third stage, it starts to get invaded with the other parts of the body. The fourth stage, it is completely spreading throughout where the lymph glands, your salivary glands, your nervous system, and it spreads to all other tissues around the area, which has been the fourth stage, and it is the last stage of the patient. Right. The next slide. Now, I'm going to talk about the oral cancer. So there are different types of cancer. Different organs are getting involved in this. But today I've selected the anatomy of the oral cancer we'll go through, right? Okay. So this picture will help you to just view the different parts of the oral cavity, where you have lips, you have a hard palate, your incisor tongue, your mandible jaw, and internally where you got your pharyngeal pharynx, your epiglottis, your hyoid bone, your thyroid gland, and your esophageal gut, your trachea is all involved in this when it comes to subject of oral cancer. Next slide, please. Okay, so as I've told you, you might find this cancerous cell. There might be an unhealed ulceration of your tongue or your cheek. When it initially you find an ulcer, it gets cured by within a week. But when it has been unhealed for a long time, then it is always better for us to go for a checkup. This unhealed mass sometimes leading to difficult in eating, talking, swallowing. So these are the signs which also indicate that you need to go for a checkup immediately. Next slide, please. Okay, in this, I have shown you the glands and the duct which has been involved. This is to show you when the patient enters the third stage or the fourth stage of the cancer. Definitely, the salivary gland, your parotid gland, all these are getting involved, and patient finds really very difficult in swallowing, or even because of improper masticating of the food particles, which also leads to a lot of dysenteric problem too for them. And next slide, please. In this slide, you will see it is the mouth ulceration causes. What are the causes that has been involved? When people start eating acidic food for a long, when they start liking acidic foods and you take it consecutively, when they start involving or affecting your mucal area in your cheek, sometimes there are possibility for you to get ulcers. And when your vitamin D, vitamin B12 or your iron content in your body comes down, again there are possibility for you to get blisters inside your mouth. And any fungal infections or your dental braces when you have been using for a long time, and when there is no proper cleaning or caring given to them, they might cause a little bit of ulceration in your gums, and which is not being treated, and persistent of this might lead into unhealed ulceration process where it slowly changes into cancerous tissue. Next slide, please. Okay. In this slide, I just see for causes, when you take into causes, the primary causes is really very unknown. But what eventually in the studies that we have come across is your tobacco, usage of cigarettes, and consumption of alcohol. Due to the chemicals involved in there, these are some of the causes which we have found out. But then when you tell cancer, the primary cause of this cancer is really very unknown. But technology and studies have improved so much that today we really don't have to worry if you do a good examination and meet your doctor quickly. There are people helping us to come and fight out with this in a wonderful way. All right, the signs and symptoms when you take up, usually there will be swelling and thickening of the lips, gums, or your cheeks, and you might find a white patches or a red patches which has been unhealed for a long time. Your soreness of your face or your voice might change. There might be difficulty in chewing, difficulty in swallowing the food that you've chewed well, or persistent ear pain, or your jaw stiffness, when it is bleeding for more than 3 to 4 weeks, then definitely you guys need to check on it. When your patients are complaining about this, please let your ears and a little bit sharper enough to rule out this in an early stage. What happens is the complication behind this is dysplasia. That is, it means you are unable to chew your food, and you are unable to swallow it also. So due to this, due to the jaw stiffness, the patient might tell the persistent of the the tooth pain. But sometimes when you go for investigation, it might not be a tooth pain. There might be restrictions in your mandible ROM, okay, range of motion. So what happens is, again, when there is no proper your intake of food is not proper, and which also might leads to xerostomia, which is nothing but dryness of mouth. So God has designed us beautifully that when we get, we want to swallow, it is a little easier for us. When we want to moisture your tongue, automatically your salivary glands work so well to keep your tongue moisture. But for these patients, they complain about the dryness of mouth, and due to this, again the chewing is getting a little affected. So patient will ultimately go for dehydration, which will eventually lead into weight loss. So when there is a weight loss, how it will get your immune system is also affected, and patient finds really very difficult to fight these cancerous cells. Okay, fine. So we'll move to the next slide. Okay, in this, the diagnosis, the first and the foremost, I will tell you guys to look onto your self-examination. How do you want to do it? Go stand before a mirror, open out your mouth wide enough as far as possible to check out your mouth. Just hold your tongue down, bring it out down, and check your left side of the cheek, your upper portion of your tongue, your lower portion of your tongue, your lateral side of your tongue, and as well as your lip up and down. And please do see internally to the maximum extent that you can to find out any color discoloration or any patch is involved. So self-examination is really very important in this. If you are unable to do it and you have a doubt that you're swallowing and other things are getting you have ear pain and other things that gives you a small doubt, please do go to a dentist and do a thorough examination. So when they do this, if they find something unusual inside, or the tissue is growing unusually, if it has been viewed through their eyes, then they might send you an oncologist who can do a biopsy for you and send it for investigation process. All right. So the treatment part is as usual. If it is really very suspicious and the tumor, they found a real very tumor of your thyroid glands or something like that, then the excision of their part has to be done. But then we always follow with a good chemotherapy and a radiation therapy. So today the radiation therapy has been, like it has been used so well to treat these cancerous cells. They also do the PET scan and where they might find whether there is an invasive of these tissue into the other parts of the body too, right? Fine. How to prevent it? See, prevention is better than cure, right? How to prevent it? Please do a self-examination regularly. Have a good oral hygienic practice. Wash your, after your food, please wash out. And when you use out your dental braces, please clean it thoroughly. Have a good checkup with your doctor. Hope you guys are following me, and I hope I'm not boring you on it. All right. And you also need to avoid tobacco and smoking. See, when you come across, guys, we need to have some social responsibility too, right? When you find your small dealers and your small shop dealers where they are selling all these tobacco, these cigarettes, please go talk to them, to tell them, you educate them regarding this. They might sell these products even without unknowing too. But today everything goes into a commercial level, and there are people who sell for money too. But then, guys, it is our responsibility to talk, to tell them to avoid such things. Why is, if you could see this next slide, this patient whom I'm showing, This is why I selected this topic today, this morning. See, one fine day, this patient was sent to me by an oncologist. He called up and told, ma'am, can you help out this patient? Because he has been found out with oral cancer, and the surgery has been done 1 month prior to when they met me. It has been 1 month, or the surgery has been completed. So he just told me the patient is unable to open his mouth, and he finds really very hard to take even or sip even a spoon of water. The wife came and cried to me, telling, ma'am, do something. I want to give my husband a few drops of water, or make him to drink at least few milk, so that he might live. You know, I was so moved to see this guy. He's only 30 years old. You know, they knew that tobacco is going to hurt them, but they are consuming it. All right, it is their mistake. But then right now, if they have come to us for an help, how can we go proceed with this? So, you know, after prayer, I just took up this case, and after going through the case sheet, before planning, young buddies or the students who are listening, please listen this. Before planning your treatment process, please go through the case sheet, the surgical notes completely. Based on these notes only, you can decide what to be done to this patient, right? See, exercise is a role. We know what exercise, even you guys who are, even if you are not in a first year or second year, you know what to be taught. But then to whom you should teach this, and what you should teach it, when to teach this, these are the very essential things that is known only to a physio. That is where our role plays a vital role in this. Physios are really the salt of the entire process of recovery of the patient. Only when you add these salt into it at the right time and the right proportion, you can make their life very much valuable to the extent of where they live, right? So that is where our role plays a wonderful job. So when this patient was there, keep the previous slide itself there. Keep the previous slide. When this patient was there, what I decided is to do a little bit of a small manipulation to both the TMG joint. Okay, so I slightly did a little bit of manipulation. I slightly gave him a little bit of massages, since he doesn't have any fresh wound. It has all been healed since it is 1 month. So when I started doing it and mobilizing his TMJ joint, then patients we are able to view there is a little bit of difference in the joint mobility. So for these type of patient, you can't put any sort of an electrical modalities, since internally there are a lot of suturing is being done and a lot of corrections has been done. They would have tied the tongue, posterior end of the tongue into the cheek. So it is not how we are moving the tongue they will move. It will be really very difficult enough. So after the end of the 10th day, I was able to bring him to only this much, guys. I was able to put a spoon into his mouth, and for this itself, the patient felt really very happy that they were able to take food orally, without Ryle's tube, they were able to take the food. All right. So after this, my role didn't finish. I finished my role with the patient, but I made a point to talk to my oncologist regarding this. So when I started discussing all this story behind what happened inside my room and how much of pain the patient was suffering, and how difficult it was for me to rehabilitate this patient, I requested my oncologist to use our role even in a little earlier stage. So after making him clear understanding, sir accepted my request, and he started giving me other cases where henceforth my role played a wonderful job in rehabilitating them. Next slide, please. In this patient, you guys might view, I am rehabilitating the patient on the POD of 2, post-operative surgery day 2. All right. So first day after the surgery, I visited the patient. I gave a few, word of warmth and consoling them that we are around as a team to help the patient to fight this dangerous cell. So the next day, after talking to them and giving them a good hope to them, the next day when I visited this patient, I told that what I am going to do them, and I educated them. And you guys could see in the picture, there might be a Ryle's tube fixed to the patient. There you might find the drainage, drainage tube is also there. This is to collect the fluids, unwanted fluids from the mouth. So for this patient, before entering, I went through the case sheet really well. I understood the type of surgery which has been done to this patient too. So after that, I started, the day POD2, patient wants to spit out the fluid from the mouth. That is what they will be expecting from us. So I gave him a gentle stroke on his, the non-surgical side, and after putting gloves, keeping yourself really very sterile, giving them a good stroke, and made them patient to bend a little, because your DT is here. They can't flex the necks really well. So bend a little and slightly tilting the head to the non-surgical side, and made the patient to spit out the saliva, just flow out it, so that all the fluids that has been collected, it will enable out to come out, so that patient might feel little freeness in the throat. That is all I did for this patient on the POD2. The next day, guys, please wear your gloves. Please take up the gauze. Don't expect any sister to be. Once you're thorough, see, juniors, please take the guidance from your seniors when you start working. But then other people, with few experience into, go touch your patient, give them the comfort. God has given us a beautiful fingers for us to, to help them, right? Use it, guys. Use it for them. Use it for the patient. Use it for the so you try to clean their mouth and leave it. They feel so happy that the comfort the first day when they get will be remarkably good. The next day when you go in, patient will have pain on the surgical side, because the epidural, everything they would have stopped, and the painkillers, it would have come down. So patient will have pain, but make sure you rehabilitate the patient on the POD3. Ask them to open the mouth as far as possible. Ask them to close out. If you find any secretion, with the help of your seniors there, you can put a little bit of suction with a very minimal pressure. The suction pressure should be really very minimal. Check it out in your hand. You might find out or adjust it out so that you can clean it. Because if you're going to put a real good hard suction pressure, then you might injure the surgical site too. So you just put a suction where the external part of the mouth is being cleaned. Or if the patient is cooperating with you really well, you can just make them to spit out the fluids, right? Then start rehabilitating them with all the exercise. So this patient, when he left after the after this course, he was able to talk, he was able to swallow, he was able to eat. There was no rice tube required for this patient. So when they went like that, you are adding a little valuable to their life, right, guys? So you will find the joy, you will find the bliss enough, and how much you guys are really blessed with. So make sure you rehabilitate these patients. Shall we go on to the next slide, please? Okay, now I'm going to teach you a bit of rehabilitation process, which you all know, but then it's my duty to teach you guys, and you guys build up on this, all right? So these exercises are the general exercise that you will see it in the slide, but you keep it in mind that wherever the surgery is being done, the patient's tongue would have been the behind portion, or your cheeks, they would have cut and they would have tied it, the lower end posterior part of your tongue, they would have sutured it with your gums or with your cheek process. So patient will not be as able to use his tongue. But then these are the exercise that are basic exercise that you can teach free of, and even in the post-op, depending upon the tongue mobility and the jaw mobility, all right? So the first exercise is your mouth exercise, where you ask the patient to open out your mouth really very well. See, when a normal patient opens out his mouth, when you open it to the full range, you can keep your 4 fingers inside the upper and the lower tooth. You can keep it, guys, but then or you can at least keep your 3 fingers into it really very good. But then when it comes to these type of a patient, please make sure they should keep 2 fingers. They require this space for them. You aim at 3, but you make sure they are doing at least 2, so that their swallowing and the eating difficulties patient will not suffer in the future. So as I've instructed there, you can make the patient to open this mouth as far as possible to make with that sound. Hold it for 5 seconds and close his mouth, and repeat this for 10 times. It might be not 10 times, depending upon the day of POD. You can maybe 4 times, 5 times, as the patient's ability, you can plan accordingly. And the next exercise is the jaw exercise, where you can move the jaw to the right or the left, like this. You can move it to the right or the left, where the TMJ joint will not be restricted. The jaw stiffness will be avoided, which will enable them to chew. All right. The same procedure. Ask them to move to one side, keep it for 5 seconds, then again to the neutral position, then again to the left, again to the neutral position. Always make sure the patient comes to the neutral position and then go to the either side of the mouth. Next slide, please. This is the swallowing exercise. This is really very difficult, guys. It's very easy to teach, but the patient finds it really very difficult to do this. Teach them very slowly and make them understand. What you need to do, ask the patient to bring out the tongue as far as possible and hold it between the two, your upper and the lower teeth, and then you ask them to swallow a little. Okay, between the teeth, ask them to hold the tongue, and then you do a little bit of swallowing, so that the patient will not fold his tongue. He can't fold because the suture will be there, but still, when you teach them in this way, gently When they do it for the first time, please keep your fingers on their throat and give them a stroke and feel whether the patient is swallowing or not. Don't just stand and just view them. You won't be able to see whether they are swallowing. Just go to the patient, touch them, see them, and then give them a gentle stroke so that they might swallow it. Okay, so again I've given you my the same way. Ask them to do 5 times, and depending upon the patient's puffiness of the throat. Okay, fine. And same way, ask them to teach them huffing also. I haven't I'm sorry guys, I haven't mentioned it here in the slide. Teach them little huffing technique also. Don't make them to cough, because it is very difficult for them, but then teach them huffing slowly, which the patient will learn to do the coughing techniques too. In this slide, I've shown you the pictures for your tongue mobility. So the first picture, ask the patient to bring the tongue up and place it on your teeth, on the upper teeth. So, and give them a little pressure. Hold it there. Again, bring back to the neutral position. This is because it is like an isometric. You're pressing it. Okay. So how much ever the patient, don't ask them to protrude out. I want them to just place it on the teeth and just give them like an isometric compression. Okay. So the next the exercise 2 is to protrude the tongue out and ask the patient to try to touch the nose. But then guys, don't go with the pictures. Always keep consider that the patient, when they might not be able to do this due to the sutures. Then again, tongue depression exercise is there. Then again, the fourth one is to ask the patient to move the tongue to the left or to the right. Again, if the suture has been done to the left side, don't ask the patient to move the tongue to the left. He will not be able to do it. Concentrate on the right. When the suture has been done to the right, ask them to do it on the left. Patient have to do it, because only then they will be able to try chewing and swallowing will be easier, right? These things can be taught to them in a very gradual way. By the end of POD 5, try to make sure the patient is doing every exercise of this, right? Then again, the click sound, that sound here, right? So you can ask the patient to make that sound. Okay, fine. These are small things, small exercise, guys, which you all would have known. But when you really touch the patient, why I made you selected this topic. It is really very difficult for them to do it. Okay, the next slide, please. The strengthening exercise. See, whenever you teach an exercise, it is always, guys, you should strengthen doing, you should end up with all the strengthening exercise here, because when you just leave it, only the exercise the patient might do, but it will not get strengthened. So you guys need to concentrate on the strengthening exercise too. As the picture clearly explains you, you can place your hand, near the chin, and give them a little pressure. All this strengthening exercise is only after POD, 6 or 7 or 8, only in that range. Until then, sometime it might get delayed also, depending upon the patient's tolerance. But make sure you teach them these exercises so that a good strength, or you're making the T.M.G. joint really very good and strengthening it out, so that the patient will be able to chew solid particles, or you'll be able to bite, you'll be able to chew solid particles too. Okay, the second thing, and the second exercise, as you concentrate in this, I will make the patient to hold the spoon between holding with the lips, not with the teeth. It is only with the lips to strengthen your oral muscles. Okay, So when they are able to hold it for 10 counts, and then they can release it. So the next stage of it, you can keep a small, you can keep a small lemon or ask the patient to balance it out so that a little bit of strengthening exercise can be done. But make sure, as I'm repeating it again and again throughout the session, telling you that make sure the patient's condition and the surgery and the POD, all these plays a very important role in giving a good rehabilitation to the patient. All right, guys. So just rehabilitating only the oral cavity alone is not going to help you. We need to think about the other muscles too. So next slide, please. In this, I've mentioned the cervical isometric exercises. Why isometric is patient might have the DT, or they would have, like a central line. There might be a central line on the other side. So when you ask the patient to move the head up and down, it might be really very difficult. So always go up with an isometric exercises. The experienced people will know what are the cervical isometric exercises. The young buddies, I'm sure your lovely professors, your lecturers will guide you on how to train you on this. The next slide, please. I've just shown you a small, the picture might clearly explain you. The isometric means there is no movement of the joint, just you're working on your ligaments there, like your just the contraction we want, just the contraction we want. We don't want the joint to be moved much, but the muscles has to be give them the spark that it has to work out. All right. So these isometric exercise can be taught to the patient. Then you please make sure, the next slide, please make sure that you also teach the isometric shoulder exercise too. The next slide, please, ma'am. In the shoulder exercise, why I'm insisting on this is, the shoulder movement, not only isometric, even all your shoulder movement is very important, because when the cancer, it spreads to your oral cavity, guys, and it start involving the nodes, or sometime the nerves. The surgery, they would have removed the section of the nerves would have been done, clearation of the nodes would have been done. So when there is a nerve involvement of the surgical procedure, again your shoulder shrugging, your shoulder elevation, depression, all these might get affected. So please make sure that you teach a little bit of shoulder exercises to enable them to move the limbs also. When it comes to breast cancer, of course, you guys are all well aware that you definitely need to train them on your hand, because of the removal of the nodes. Even in the mastectomy cases, they do. Even for oral cancer, as when I was preparing for all this, when I spoke to the oncologist, even for the oral cancer, they removed, or they might remove all the nodes, depending on the invasion of the cells, and sometimes they might work on the nerves too. That is why patient might not use their limbs in a much greater sense. So please teach them the exercise. And I want you guys to keep in mind that even when there is an involvement in the nerve of your tongue, your glaucopharyngeal nerve, and other nerves, your cranial nerves, when it get affected, you might feel asymmetry of the neck or in the face scene. But to those patients, concentrate much on your strapping, your exercises level, and you can't put into much of an electrical modalities because of the cells are much tender to all these processes, right? So when you get a patient, just think and plan your rehabilitation part. All right, the next slide, please. Okay, So, friends, as in this slide you might see, I pray that you might all enjoy good health and that all may go well with you. And I also tell all my patients, students who come here, who has been associated with me, I always tell them, keep your soul clean. What is soul? It is nothing but your thought process is your soul, right? So when things are going very commercial in these days, guys, when you need to don't go really very commercial, keep your soul very clean. And because when you keep your soul really very clean, doing the right decision for the patient at the right time and treating them and rehabilitating them and keep yourself happy. So when we have a chance to meet our creator, our spirit will encounter with them in a very joyful way, right? So this is my small presentation and I'm so happy. Move to the next slide, madam. The thank you slide. Can you move to the next slide? See, guys, I've given you my number there. If you have anything, if you want to talk to me personally, or if you have any questions apart from the subject, if you want any guidance too, please do. You can contact in that number, or you can WhatsApp me in that number. Whatever knowledge that God has given me, the experience that God has given me, I can teach you, or I can help you on it without no pride from my side. Okay, so please do keep in touch, and I thank you all the faculties there who made me to talk this morning. I thank you, the principal, for giving me this opportunity. I thank Dr. Janani, Dr. Kamakshi, who really associated with me so beautifully in doing this presentation to you all. God bless you, and a great journey of physio. Be happy and really very proud that you are a physio. God bless you all. And if you have any questions, you can ask me. Thank you so much.
Students, if you have any queries,
Thank you, madam.
can
Thank you very
post in
much.
the chat
It was
box.
a nice presentation.
Thank you, sir. Thank you.
Over to Aishwarya.
Yes, sir. Students, if you have any queries, you can post them in the chat box. Students, chat box is now enabled. You can post your queries there.
Hope I was useful to you all.
Yes, definitely, ma'am.
Yes, ma'am. Yes, ma'am. Okay, ma'am. I think students don't have any doubts because your session was really clear enough. You gave a very good coverage of various concepts in oral cancer and the main role of emphasizing the role of physiotherapists in rehab. And you gave a very good demonstration using pictures. So I hope the students would have understood really well. So without much ado, it's time to introduce the next speaker for the session. So I would like to invite Dr. Deepthi, Assistant Professor, for introducing the next speaker of the day, Dr. Parvati ma'am. Deepthi ma'am, over to you.
Aishwarya.
Good morning. Good morning, everybody. Hope I'm audible. Aishwarya, ma'am.
Yes, yes, yes. Yes, ma'am.
I'm very glad to invite the second speaker of the day, Dr. S. Parvati. Parvati, ma'am, graduated from UCA College of Physiotherapy in the year 1997. Started the career as a clinical physiotherapist at Tamil Nadu Hospital, now as Global Hospitals. And she moved to academic side in the year 2002. Ma'am has worked as a lecturer in Sri Balaji College of Physiotherapy, and she completed MPT Neurology from SRM College of Physiotherapy. And ma'am joined as an assistant professor. And she's done rehabilitation for around 90 total joint replacement cases. And she's attended many neuro patients. And ma'am has overall about 23 years of practice. And she's a trained prenatal and postnatal and a lactation therapist. And ma'am's currently working in Dr. Kamakshi Memorial Hospital and Genesis in the Women's Specialty Hospital in Chennai. We welcome you warmly, ma'am, and thank you for the opportunity.
Good morning to everyone present here.
Good morning, doctor.
Good morning, sir. Very good morning. It's so nice to interact with you once again.
Good morning, Dr. Parvati.
Thank you, sir. Thank you. Good morning. First of all, I would like to congratulate the previous speaker for such a wonderful presentation she did, emphasizing the role of physiotherapist in that particular field. It was such an encouraging presentation.
Thank you, ma'am. Thank you.
Thank you for the good presentation. First of all, I would like to thank the management of Dr.M.G.R. Medical College and the physiotherapy faculty, principal, the staff, and the students for giving me an opportunity to talk about this topic today. This is a special day. So I also extend my best wishes to all the physiotherapy fraternity. Let's grow together, empower ourselves with knowledge and skills so that we can serve the community in a better way. Shall we start the presentation? I hope I'm audible. Am I audible?
Yes, ma'am. Yes, ma'am.
Yes, yes.
Can I start sharing the screen?
Yes, ma'am.
Yes, ma'am. You can go ahead.
I hope the screen is visible to everyone, right? Is it visible?
Yes, ma'am.
So the topic of today is the impact of COVID-19 on our nervous system. From the point of view of a physiotherapist, how important is the impact of COVID on our system is what we are going to see today. Just a minute. Now, this is the first slide. So let's start with the definitions of what is COVID-19. As we all know, it's an infectious condition caused by SARS-CoV-2 virus with acute symptoms which can last from 5 to 6 days to 2 to 4 weeks under normal circumstances in a healthy person. Okay, so this is the acute condition is called COVID-19, and the symptoms can be of 3 types, where the first category is mild symptoms, the second category is moderate symptoms, and the third category is severe symptoms. Okay, so as we all know, it is quite famous, but the mild symptoms are quite famous. It's nothing but fever, dry cough, and tiredness. And most of the healthy persons with healthy habits, and provided they are young without any comorbidities, just go through this infection, come out of it within 5 to 6 days. And this is a mild form. When it comes to a moderate form where they're a little older or a little more prone to the effects of COVID, they may encounter aches and pains in the body, sore throat, diarrhea, conjunctivitis, headache, loss of taste or smell. We call it as anosmia if it's complete and hyposmia if it's little reduced, and sometimes even skin rashes. So last but not the least one is the serious kind of symptoms where they encounter difficulty in breathing, dyspnea, chest pain or pressure on the chest, and loss of movement of the limbs or speech also. So this is about the acute COVID-19 normally. Then what comes is the long COVID-19. So you all must be wondering, like nowadays, the theme itself is long COVID-19. And what is this long COVID-19? If the effects of the COVID-19 infection persist for more than 4 weeks after the diagnosis, which is around, which can go up to, so far, whatever studies they've done, it has come up to 6 months. It may be longer also, it has to be decided. So if the effects last for more than 4 weeks after the diagnosis, it is called as post-COVID-19 syndrome. It is also called as post-COVID-19 conditions. So students, when you get into practice later and when you come across these terms, you should be confident that it is nothing but long COVID-19 which you are going to deal with. So 10 to 70% of the COVID-19 affected population are more prone to develop long COVID-19. So who are at risk? Which population is at risk of developing long COVID-19? Anybody can develop this long COVID-19, but still there are certain people who we can say are more prone and they can be more careful and watched in a better way. They are adults over the age of 40. With see the age of 40, above the age of 40 means like kind of sedentary, like their lifestyle may be sedentary, they may be obese or with what to say, not a good lifestyle habits. Then people who have experienced severe symptoms in the acute infection, like who have developed breathing difficulties and like loss of movements or weakness of movements, and all those people, and who were admitted in hospitals and probably into ICUs and have taken more time to recover from it. Then individuals with underlying health conditions like cardiopulmonary issues, hypertension, diabetes, obesity, etc. So this is called long COVID-19. And the role of a neurophysiotherapist, I think, is more in long COVID conditions than in acute COVID condition. So what is the role of, like what are the manifestations it does to the nervous system? Though the major area of concern is respiratory system, it can extend to any system. So when it extends beyond the respiratory system, one of the dangerous areas which may be affected is the nervous system. And we are also, like observing, and various studies also show there is a wide range of neurological manifestations in the post-COVID conditions. So why this kind of manifestations happen? What is the pathophysiology behind it? That we will just see as a gist. So all these are hypothetical, okay? Like this is how we come to a conclusion that yes, this can be this route, like this, it can be affected like that. Studies are still going on. So the first point in the pathophysiology will be an invasion through the olfactory route. So if you see ACE2, angiotensin converting enzyme 2 receptor is this is the short form of that. And this receptor is present in the nasal mucosa. It's present in the the inner layer of the blood vessels. It is present in many major organs like brain, lungs, kidneys, everywhere. Okay, so these receptors which are present in the nasal mucosa are the ones which are affected by the virus to start with. And from there, it enters the main circulation and reaches the cerebral circulation. Cerebral circulation, if you see, it's a microcirculation where the movement is little sluggish to nourish the parts of the brain. And in that sluggish movement makes it easy for the spike proteins which are present in the virus to interact very well with the ACE2 receptors which are present in the capillary endothelium, making the infection, giving more entry into the central nervous system. And from there, it affects. The evidence is seen in MRI scans where there are more inflammatory markings in the olfactory cortex of the brain, which supports the first hypothesis. Okay. The second one, let's see the cytokine storm. You all must have had that the need for the patient to get admitted into the ICU and get into mechanical ventilation, and all this is because of the cytokine storm, which starts approximately from the 3rd day of the infection. So what is cytokine storm? It's nothing but an uncontrolled continuous response of the inflammatory system, resulting in release of a lot of cytokines into the bloodstream as an inflammatory response. And when the cytokine storm happens, it results in ARDS, acute respiratory distress syndrome. This is what leads to ICU admission and mechanical ventilation support and all that to the patients. Okay. So then comes pneumonia. So this is the first sign, when the respiratory system is affected, the patients get what is called as pneumonia, which affects the lungs and brings fibrosis kind of changes. So this leads to systemic hypoxia. Thus, the oxygen supply to the brain is reduced, which can result in more inflammation and neuronal swelling and brain edema. Okay, then the last one is the immune dysregulation by the hypothalamus, which is again the effect of the cytokine storm. Okay, because of this, the hypothalamus is confused and it affects the systemic immune regulation, the response. It is not happening in the normal way. Then it leads to gradual multi-system failure, resulting in many imbalances like systemic water imbalance, electrolyte imbalance, hormonal dysfunctions, and accumulation of toxic metabolites. And all these changes together can lead to one by one neurological manifestations. Okay, I hope it's clear till this. Is it clear? Coming to the neurological manifestations, let us see generally what can happen when the virus invades the central nervous system, peripheral nervous system, autonomic nervous system, everywhere. Generalized symptoms can be, like you can see, observed symptoms of encephalopathy, encephalitis, where there is inflammatory changes observed. There may be more chances of acute cerebrovascular diseases ending in stroke of different levels, from paresis to paralysis, and brain perfusion abnormalities because of hypoxia. Then comes meningitis, which is inflammation of the coverings of the brain. Myelitis, inflammation of the myelin sheath covering the nerve fibers, and ataxia, where the cerebellum is also affected. Then you have to talk about ICU-induced neurological manifestations for those who spend from minimal to maximal time in the ICU. In the acute phase, mostly what they encounter is altered mental status, delirium, which is mainly due to the hypoxemia to the brain and high doses of sedatives under which they are kept for the therapeutic purpose. Post-infectious complications, like we saw in the pathophysiology, there is dysregulation of the immune response through the hypothalamus. So this can affect the central nervous system and cause acute disseminated encephalomyelitis, acute necrotizing hemorrhagic encephalopathy. This is regard to the central nervous system. Common manifestations you encounter. The commonest peripheral nerve involvement can result in Guillain-Barré syndrome. In that also, especially the Miller-Fisher variant, where the cranial nerves are targeted more than the other peripheral nerves. The most important and commonly missed out in our country is the neuropsychiatric manifestations of the affected patients. This results mainly due to the isolation issues, like isolated in hospitals, like home quarantines, long home quarantines. When there is lack of stimulation, when there is lack of social interaction, the neuropsychiatric manifestations can result. And if they already have an inclination towards it, then they may be worsened. The list of neuropsychiatric manifestations which you can commonly encounter, because as a therapist, when you approach the patient in the post-acute period or later rehabilitation period and all, they may still have some remnants of these neuropsychiatric manifestations which you have to address and regard it and work, do something for that as a team. So your team will definitely have a psychologist or a counselor who will be like experienced enough to deal with such situations. So the common manifestations are depression, anxiety, loneliness, post-traumatic stress disorder, anger, fear, restlessness, irritability, and negative psychological well-being feelings. The feelings of negative psychological well-being may result due to all the effects from the isolation and social distancing and all that. Coming to the autonomic nervous system manifestations, when the symptoms become chronic, that means when they extend, the effect of the COVID-19 extends beyond 12 weeks, then the studies say that there are chances of the ANS getting involved, either through viral mediated disruption or through immune mediated disruption. Okay, so the symptoms may include orthostatic hypotension, the vasovagal syncope due to abnormal stimulation of the vagus nerve, postural orthostatic tachycardia syndrome, palpitations, chest pain, and breathlessness. See, the autonomic nervous system manifestations are very important for fresh people who are assisting their seniors in rehabilitating the patients, because in your mobilization, like when you make the patient, when you change positions, when you make them sit in the bed near the bedside, or make them stand for the first time, or try to mobilize them with a walker, they may seem to cooperate well and do very well to start with, but when one of these symptoms crop up, then you don't know, like if you are not experienced and you miss to identify them, then it can be dangerous for the patient. These things have to be kept in mind when you are going to rehabilitate the patient. Okay. So now, what about the pre-existing neurological conditions, like the patient already has a stroke and he's recovering from it, or any other common neurological conditions, and they have now additionally been infected with COVID. Now, what happens to them? Like you are dealing with them already, or now you are about to treat them. So, what are the things to look out for? Like I've taken few common examples. Like now, let us see about the stroke patient, cerebrovascular accident, after which they've been recovering and now they've got COVID. So what you can expect will be like naturally the outcome is going to be poor compared to the other normal patients. And these patients have greater risk of going into ICU admission, and the discharge rate is also going to be poor. There are more chances of going into mechanical ventilation also. They have very increased chances of getting into, again, the cardioembolic events because of the angiotensin converting enzyme 2 receptor and new cardiovascular events as they have a history. Okay, so this is about the stroke patients. We have to keep in mind all these things, and like your expectations, plan, and delivery of your care should be based on these facts. Then the Parkinson's disease, where naturally the age group is going to be older. Again, there is a poor outcome, which may also be associated with exacerbation of symptoms, whichever symptoms they present they've been presenting themselves with. There'll be a lot of anxiety associated with the patient, and there is a possibility of medication errors when they are in the ICU or in the ventilators, which will again interfere with the exacerbation of symptoms. So the next common condition is dementia with old people, where already there is a problem with memory. Now it will be associated with a lot of cognitive impairments like concentration, comprehension. Again, there will be a reduction in the memory capacity, and they'll have a lot of delirium, which is again due to the cytokines, a lot of production of cytokines and prostaglandins into the systems. Then coming to spinal cord injury, whichever level of injury, the pneumonia is going to have a big impact on these patients. That is the first thing which we have to look at and plan accordingly. So this is about the pre-existing conditions and how they can affect our rehabilitation post-COVID or in case of long COVID-19. Okay, so coming exactly to the rehabilitation part of it. See, for our understanding, I've divided it into three parts, where the first is acute care, then the post-acute care, and long-term care. So mostly the acute care will naturally be in the hospital. So where they are going to be, whether they are going to be in the ICU, even in the ICU, whether they are going to be under mechanical ventilator matters a lot. If they are just admitted in the hospital and being observed, then you have your role to play there also. So the clinical parameters have to be continuously monitored, like the oxygen perfusion, blood pressure, and heart rate, and all continuously monitored even when you are going to deal with them. Like what we can do is like both in hospitalized and in ICU patients also, a lot of positioning you have to do to enhance better breathing, move more oxygen into the system. Like you must have heard of proning, sideline positions. In acute care, mostly the secretions will not be a problem. But if there is a previous condition which is aggravating the secretion issue, then you have to position them for based on postural drainage techniques. So mostly positioning, turning them in the bed to avoid complications related to long-term admission in the ICUs. And if the patient can stand, withstand, then he can be trained to sit on the bed, sit on the bedside, and if possible, walk. So with the help of the walker, they can be made to stand. That's all in the acute care can be attempted to keep them, fit in that level. And just sitting, standing will take care of the secretions in the blood. Now, there is no need to give any respiratory exercises, anything in the acute care. Strictly, it is not given because it will be taxing for the patients. So, in acute care, the role of physiotherapist, like neurophysiotherapist, is limited. Coming to the post-acute care, where the patient is either in a ward, special ward for COVID, or they are in their separate rooms. So there our role again starts in the post-acute care. Then the long-term care is usually after the discharge, either at home or in the rehabilitation setups. But for COVID, that rehabilitation setup care is not that much, mostly home care or in the ward only. So when we talk about rehabilitation, what are the effects of rehabilitation? Why it should be started at the earliest with the proper assessment? What are the benefits? No, it will optimize the health outcomes of the patient, and early discharge can be facilitated. Now the situation is like that, they don't want to keep the patient unnecessarily in the hospital. One is for the fear of getting secondary infections or this patient infecting the others. Once they become stable, they will discharge you and send you home. And it is the availability of beds is also, like it is under the. So the earlier the rehabilitation starts, you can plan for early discharge. Okay. And there are certain factors which will affect the rehabilitation process. So before starting the rehabilitation and assessing the patient, you have to keep certain points in your mind. Based on this, you can plan your schedule. So the factors which can influence the rehabilitation are the comorbidities which the patient comes to you, like hypertension, diabetes, obesity, coronary artery diseases. So all this have to be taken into consideration. So relative to that, you have to look out for the complications. The extent of direct lung trauma, like the amount of extent of pneumonia, how much fibrosis has happened, how much units are lost, so that the capacity of the patient to do exercise may vary and depend on that so much. So you have to just check for the extent of direct lung trauma also. Then injuries to other organs and systems, so that as a whole, the body has to work and cooperate for the rehabilitation. So the post-acute rehabilitation, when it is started, the length of the ICU stay matters a lot. Okay, because that can lead to long stay, can lead to many issues like critical illness polyneuropathy, critical illness myopathy, and post-intensive care syndrome. So what is critical illness polyneuropathy? It's a mixed motor and sensory neuropathy, where the distal parts are more affected than the proximal muscles. There is a sensory involvement in the distal parts, and this can lead to, this is associated with axonal degeneration. So complete recovery may not be possible. So early rehabilitation is planning, and planning for activities is required. And if you see, there is a generalized symmetrical weakness in the muscles. Distal involvement is more than the proximal involvement, and the diaphragmatic weakness. You can see diaphragmatic weakness, which will really interfere with the breathing pattern of the patient, breathing capacity, the amount of oxygen moving in this system. There will be atrophy seen if the stay is quite long. You can even see atrophy in the distal musculatures in the extremities. And deep tendon reflexes can be diminished or sometimes be absent also. So how do you know with the symptoms of the patient? So main symptoms can be like, if the patient comes tells you these symptoms, you have more like chances of seeing this. So just look out for these when they tell you complaints about pain and loss of range of motion, fatigue, incontinence, dysphagia, difficulty in swallowing, and there can also be cognitive loss. There can be depression, anxiety. So please look out for this critical illness polyneuropathy, particularly if you come to know about their ICU stay was quite lengthy. Then this can be confirmed with the help of EMG or muscle biopsy later. Then is the critical illness myopathy. It's a non-necrotizing myopathy, and where the proximal involvement weakness is more. This is how you differentiate it. Proximal weakness is more, and it results mostly due to the excess amount of corticosteroids, which is for life-saving, they use it, but it can end up in conditions like this, critical illness myopathy. Okay, there is fibrosis of the muscles, fibrous atrophy can be seen, and the sensations are preserved. This is also one point to differentiate it from CIP. So there is more proximal involvement, weaknesses in the proximal muscle groups, and sensation is spared. These are the two critical points to differentiate. And in this case, complete recovery is possible, provided the treatment is started on time. The intervention starts on time. So when these things are left untreated, they can result in some long-term effects like general weakness, loss of certain functions, deterioration of some ABL, then poor endurance when you take them for exercises. So you have to just look out for all these symptoms. If these symptoms are due to CIM, then that line of treatment has to be slightly modified. So coming to the post-intensive care syndrome, it has different components in it. There will be a lot of cognitive impairments, a lot of psychiatric issues, and then some physical impairments. So the physical impairments can be again dyspnea, reduced respiratory muscle strength, pain, impaired exercise tolerance, neuropathies. You can see symptoms of neuropathies, muscle weakness. So a quick way to know that there is muscle weakness is to check their grip strength. Then there will be paresis in the limb muscles. And when you make the patient stand, there can be knee extension lag. So all this shows the physical impairments of which are part of PICS, post-intensive care syndrome. And the functional capacity of the patient will be low. So the post-intensive care syndrome, the components of the syndrome as a whole can lead to, like if the patient also seems to be an elderly, there can be, the impact can be, first is poor mobility. And when they try to move with all these difficulties, there are more chances of falls and ending up in injuries and fractures. And they may even end up with quadriparesis. So we have to be very careful in checking, and in patients who had a lengthy ICU stays, we have to look out for all these things which are very common. Okay, so coming to the sequel of COVID-19 infection. So in a rehabilitation unit, you are supposed to know all these things. So when you're not surprised when they pop up, and know how to manage them. This is a list of common sequel of COVID infection on different systems of the body. The first and foremost is cardiac, because they need emergency care sometimes. So the symptoms can be arrhythmia, decline in ejection fraction, and myocarditis. Neurological, which are always secondary complications, are headache, altered consciousness. So when a patient sometimes, like if you may come across with some irrelevant, incomprehensible talks, and also we have to be ready for it. Seizures, anosmia. See, anosmia is complete loss. Hyposmia is partial loss. And there is something called chemothesis. Chemothesis is a term which they are telling. It's a specific loss of sensations, like and the patient, like the taste or smell is not completely lost. The taste, if you take, some tastes are lost, or they take time to recover, like they won't be able to taste the hot chilies or cool peppermints, like that. That is called as chemothesis. That is because of the involvement of nociceptors. So that you have to see. Sometimes when they say, yes, I can taste, but like certain tastes are taking time to recover. So that term is called chemothesis. You have to be familiar, make yourself familiar with that also. If you find that in a discharge summary or case sheet of the patient, you should know what is this. Then paresthesias means abnormal altered sensation throughout the body. Then symptoms of Guillain-Barré syndrome, GBS. Then acute cerebrovascular accident. So you can have them as a secondary impacts. Then coming to the musculoskeletal system, you can encounter muscle weakness, reduced joint mobility, impaired balance, and impaired gait. Again, that CIP, CIM, which we saw just now, and physical deconditioning will be there, pain will be there. Okay, so don't expect the patient to perform in the pre-COVID levels. They themselves will be surprised, and they may be demotivated to find the physical deconditioning, but substantiate them, make them understand with explain to them that this is perfectly normal and this is how most of them feel, and it gives more motivation and assurance for the patient to cooperate with you in a better way and come out of this issues. Then comes the pulmonary sequelae. There can be tough secretions from the secondary infections after the viral course. Then impaired lung functions, the values will show you. Lung fibrosis from pneumonia. All this should be kept in mind when you're planning for an exercise schedule. Then comes cognitive impairments, because this is very important for the patient to understand your comments, comprehend them, and come out with their own difficulties, and they should be able to express it to you. So the common cognitive impairments you can see are confusional states, delirium, and the other psychological issues which we have discussed, like depression, anxiety, anger, fear, and all those things. Apart from all these things, there are also other issues, like they'll have their limitations in their aerial. There will be communication issues, swallowing difficulties due to intubation for a long period. So as a team, you have to address all this, where there will be a speech therapist, there will be an occupational therapist. As a team, if the treatment is planned, you can bring a big difference in the life of the patient. So guidelines for rehabilitation for the physios who are attending to the patient. Determine the level of risk. That will be the first guideline, depending upon their number of days in the ICU, number of days they were on mechanical ventilators, and all these factors will help you to determine the level of risk, so that you can, within the safe limits, you can plan your rehabilitation program. Then find innovative ways to remove contact management to the maximum extent possible. Use the telemedicine facilities, the tele-rehabilitation facilities. Select the type of PPE which is required from you. Like in an ICU, if you're going as a physiotherapist, the personal protection equipment will be different, and will be more PPE is required for the therapist to protect ourselves first, so that you be safe and you don't spread it from one patient to the other patient. In a ward, you may require little lesser PPE, and in a clinical setup or for a home visit, again, you have to plan according to the need of the time. So you have to be very responsible in selecting the type of PPE which you require. Use minimum number of equipments and support from others. This is again to avoid contamination. So try to use single equipment to the patient if there is a provision, and use disposable materials or things like that. Like when you use, if you want to do resistance exercises in a later level, you can use like TheraBands, like that, which can be used for single patient. You have to make use of that, and use walking aids instead of having another assistant. Physically having another assistant, you can make use of the walking aids like walker, or walking stick, or walking frames, so that the infection is not spreading. Use separate units or areas in the hospital or clinic for COVID affected patients. One-to-one therapy is only allowed as for now, and no group therapy. Safety measures from both sides have to be followed. And the frequent health checkups for us as physiotherapists is very important to make sure that you are healthy and you are going to provide quality treatment. And adhering to the latest protocols and guidelines is very, very, very important, because the state as well as the central government, they keep adding or modifying the protocols and guidelines. As an institution or as a private clinic also, it is very, very important to adhere to the latest protocols and guidelines provided by the government and the health department. Updating information from other team members. I told you that we always work as a team. So physiotherapist is a part of a team. I will say we are an integral part of the team. I think of all the rehabilitation team members, I think we will be the persons who will be spending more time with the patients. And so we have to understand our responsibility and really play a good role in bringing some change in the life of the patients. Functional rehabilitation, when it comes, like you have to work along with an occupational therapist, and the assessment of exercise capacity and functional capacity is very important. The major things which you may assess are muscle strength and range of movement, balance, exercise capacity, cardiopulmonary capacity, and ADL will be the main part of your assessment. And if there is anything required, depending upon the condition of the patient, you have to add. And two very important points are clinical parameters to be evaluated on daily basis, I would say, throughout the treatment also. With the pulse oximeter, we keep measuring the oxygen saturation of the patient, and keep observing the patient's body language, and accordingly you can space the session. Then respiratory techniques are not to be used in acute phase. As I said, no respiratory rehabilitation techniques should be used, like inspiratory strengthening techniques or thoracic expansion techniques, or inspiratory spirometer. These techniques should not be used in acute phase, only in the post-acute and the next level of rehabilitation phase, they have to be used accordingly. The common tools which are used in doing the assessment, I hope the final year students and the master's students are very much aware of these tools, and just go through them and see how relevant are these tools to the complaints of your patient. When you plan for your treatment, apply whichever is relevant, assess them, and accordingly plan your treatment, so that you will also know the improvement. You can record the improvement on a chart on a daily basis. So the common thing which you use is manual muscle testing. Hand grip dynamometer test can be applied. Dog scale to measure the dyspnea, shortness of breath, and fatigue. 6-minute walk test to know the exercise capacity. 30 seconds sit to stand test. Then Berg balance scale. Physical activity scale for elderly can be used. Barthel index can be used for ADL. Then patient-specific functional scales, like if they are specific about like some activities or their job or their age, accordingly use that scale. And monitoring of oxygen saturation during activities is very, very important, as I said. Okay, so students and the faculty, just keep in mind that it's only a teamwork, and the team will consist of the physician who's involved, the physios of other specialties will be there along with you, the occupational therapists will be there, speech therapists, the psychologists to counsel the patients, talk to the patients to ensure their confidence, then the medical social workers. So all of these persons will form a team, and you're part of a team, but you're an integral part of the team. So teamwork is more important. As a team, if we work, we can avoid repetition of things, repeating things, and reduce the number of persons working with the patient also. So safety measures can be easily followed. So finally, I would like to end saying that you stay informed about the state and national guidelines as far as COVID is concerned. You have to establish links with bodies which are relevant, and they're doing something with networks who are doing works with COVID, and it should be an integral part. Integrate infection prevention protocols. We call it as IPC measures and PPE for healthcare workers, like when you are directly dealing with the patient. These are the 3 important things which you have to keep in mind. I hope it is clear till this, and if you have any questions, please feel free to ask. Is there any questions from the students?
Students, any queries? You can post them in the chat box. Chat box is open now. You can post your queries there. Sure. So I think there are no questions, ma'am. So your session was really interesting. The concept is really vast, but you explained them in a more simplified way. Thank you so much, ma'am. So we have come to the end of the session almost. So I now call upon Assistant Professor Dr. Arun Selvi to render the vote of thanks. Arun Selvi, ma'am, over to you.
Thank you, Aishwarya. Good afternoon to all. Myself, Dr. J. Arun Selvi, Assistant Professor, Faculty of Physiotherapy. It gives me immense pleasure to deliver the vote of thanks for this event to all the participants present here. I would like to thank our Honorable Founder Chancellor, Thiru A.C. Shanmugam Sir, respected President, Engineer A.C.S. Arun Kumar Sir, Honorable Secretary Thiru A. Ravikumar Sir, and respected Vice Chancellor, Professor Dr. Geeta Lakshmi Ma'am, for their constant support and guidance. I would like to extend our sincere thanks to our beloved Principal, Dr. C.V. Sendilnathan Sir, for his words of encouragement. His able guidance has always encouraged us. Thank you, sir. I also thank our Vice Principals, Dr. Veena Ma'am and Dr. Rajalakshmi Ma'am, for their interest, support, and commitment in all the events. I thank our special speakers, invitees present here in this virtual platform, Dr. Rupana Merlin Jaising Ma'am and Dr. Parvati Sampath Ma'am. Thank you for your valuable talk on physical rehabilitation for oral cancer and impact of COVID-19 on our nervous system. Thank you, ma'am. I owe special gratitude to the IAP Women's Cell, Tiruvallur district. Last but not the least, I thank all the students, staffs, and participants present here. Once again, thank you everyone. Happy World Physiotherapy Day. Thank you.
Thank you, ma'am. So we'll end up the session with the national anthem. Participants, the feedback link will be posted in the chat box. So kindly fill and submit the forms.
WhatsApp.
Participants, kindly fill up the link and submit now. The link is available now in the chat box. So submit before 2 p.m. today.